Hello everybody, we are on a Dr. Y channel, and I am Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia, and we continue to talk about your big exams questions, and today's questions are all around cirrhosis, no, liver cirrhosis of course, or hepatic cirrhosis. So take your pens, papers, my friends, to make the notes. It's absolutely necessary to remember what we will talk about. Okay, what is cirrhosis? Cirrhosis is a late stage of hepatic fibrosis that has resulted in widespread distortion of normal hepatic architecture and functioning, of course. Cirrhosis is characterized by regenerative nodules surrounded by dense fibrotic tissue. Symptoms may not develop for years and after nonspecific, for example, and often nonspecific anorexia, fatigue, weight loss. Late manifestations include portal hypertension, ascites, hepatic encephalopathy, and when decompensation occurs, liver failure. Diagnostic is usually made by using non-invasive imaging, although liver biopsy is required on rare occasions. Management involves supportive care and treatment of the causative liver disease. Okay, so cirrhosis is the 14th leading cause of death worldwide. About etiology, the cause of cirrhosis are the same as those of fibrosis. Of course, actually the same thing. In high resource countries, most causes result from chronic alcohol abuse, chronic viral hepatitis B and C, or non-alcoholic steatohepatitis, NASH. So if you hear NASH, NASH is a non-alcoholic steatohepatitis. No, steatohepatitis if you want. NASH is that. So in parts of Asia and Africa, cirrhosis often results from endemic chronic hepatitis B. Cirrhosis of unknown etiology, so-called cryptogenic cirrhosis, is becoming less common as many specific causes, for example, chronic hepatitis C, of course, NASH, are identified, as many specific causes are identified. Injury to the bile ducts also can result in cirrhosis, as occurs as mechanical bile duct obstruction, primary biliary cholangitis, and primary sclerosing cholangitis. About pathophysiology of cirrhosis. There are two primary ingredients: hepatic fibrosis and regenerating liver cells. Cirrhosis, as we understand, is a chronic liver disease characterized by the progressive loss of functional hepatocytes, the liver cell responsible for detoxification, protein synthesis, and bile secretion. So liver cells are responsible for detoxification, protein synthesis, and bile secretion, and the formation of fibrous tissue. The pathophysiology of cirrhosis involves a complex interplay between liver injury, inflammation, and regeneration, which ultimately leads to the development of scar tissue and impaired liver function. The primary causes of cirrhosis include chronic hepatitis C and B infections, alcohol abuse, non-alcoholic fatty liver disease, NAFLD. So if you hear NAFLD, my friends, NAFLD is a non-alcoholic fatty liver disease. Once again, NAFLD, NAFLD, non-alcoholic fatty liver disease, NAFLD, and autoimmune hepatitis. In these conditions, the liver is subjected to repeated bouts of inflammation, which stimulate the activation of hepatic stellate cells. Hepatic stellate cells, HCl, HCC. HCC, hepatic stellate cell. Specialized cells responsible for producing and depositing collagen fibers in response to injury. HCS, hepatic stellate cells. The accumulation of fibrous tissue around the hepatocytes leads to distortion of the normal liver architecture, disruption on blood flow, and the development of portal hypertension. Portal hypertension occurs when there is an increase in blood pressure within the portal venous system, the network of veins that drains the blood from the gastrointestinal tract, spleen, and pancreas into the liver. The increased pressure forces blood to divert through alternative pathways, such as the systemic circulation, leading to the development of collateral vessels and varices in the esophagus, stomach, and rectum. These vessels are prone to rupture, resulting in life-threatening bleeding. In addition to fibrosis and portal hypertension, cirrhosis is also associated with impaired liver function, including reduced synthetic capacity, decreased detoxification ability, and altered bile secretion. This leads to the accumulation of toxic substances in the bloodstream, such as ammonia, bilirubin, cytokines, which can lead to hepatic encephalopathy, jaundice, and systemic inflammation. Overall, the pathophysiology of cirrhosis involves a complex cascade of events that ultimately leads to the destruction of liver tissue, impaired liver function, and life-threatening complications. Management of cirrhosis typically involves treating the underlying cause, controlling complications, and supporting liver function. So actually complications. Another question I see, complication. So complications, of course. Cirrhosis is associated with variety of complications, which can significantly impact the quality of life and life expectancy of affected individuals. These complications can be classified into three categories: those related to portal hypertension, those related to impaired liver function, and those related to the increased risk of liver cancer. So, complications related to portal hypertension. Varices. The development of varices in the esophagus, stomach, rectum, or rectum is a common complication of cirrhosis. Varices are fragile, dilated blood vessels that can easily rupture, leading to life-threatening bleeding. Ascites. Ascites is accumulation of fluid in the abdominal cavity, is another common complication of cirrhosis. Ascites can cause abdominal discomfort, swelling, and difficulty breathing. Spontaneous bacterial peritonitis. Ascites can increase the risk of bacterial infections, which can lead to spontaneous bacterial peritonitis. Peritonitis is a serious infection that can cause sepsis and liver failure. Hepatorenal syndrome. Hepatorenal syndrome. This is another serious complication of cirrhosis that occurs when the kidneys fail to function properly due to decreased blood flow and increased pressure in the portal venous system. Complications related to impaired liver function. Hepatic encephalopathy. One is one of the most dangerous, awful complications. This is a condition characterized by cognitive impairment, confusion, and altered mental status. It occurs when the liver is unable to remove toxins from the blood. Jaundice. The accumulation of bilirubin in the blood can cause yellowing of the skin and eyes. So that's jaundice. Coagulopathy, the liver is responsible for producing clotting factors, so impaired liver function can lead to bleeding disorders. Consider thromboembolic complications in patients with cirrhosis even if NRA is elevated, my friends. So increase the risk of liver cancer. Hepatocellular carcinoma. So HCC is a carcinoma, hepatocellular carcinoma. So cirrhosis is a major risk factor for the development of carcinoma, a type of liver cancer. Patients with cirrhosis require regular screening for hepatocellular carcinoma to detect and treat it early. Overall, the complications of cirrhosis can be serious and life-threatening, and there are. So, and management typically involves treating the underlying cause, controlling complications, and providing supportive care. Okay. So clinics. We understand signs and symptoms. Okay, cirrhosis may be asymptomatic for years, as long as it's compensated. Often the first symptoms are nonspecific. They include generalized fatigue due to cytokine release, anorexia, malaise, and weight loss. The liver is typically palpable and firm, with a blunt edge, but it's sometimes small and difficult to palpate. Nodules usually are not palpable. Clinical signs that suggest a chronic liver disorder or chronic alcohol use but are not specific for cirrhosis include muscle wasting, palmar erythema, parotid gland enlargement, white nails, clubbing, dupuytren contracture, spider angiomas, gynecomastia, axillary hair loss, testulary atrophy, and peripheral neuropathy. Once any complication of cirrhosis develops, additional decompensation, characterized by gastrointestinal bleeding, ascites, or hepatic encephalopathy, is much more likely. Additional decompensation is much more likely. About classification, I see. So cirrhosis is typically classified based on underlying cause and severity of the liver damage. Etiology-based classification, alcoholic cirrhosis, that this is the most common type of cirrhosis and is caused by long-term alcohol abuse. Viral cirrhosis, this type of cirrhosis is caused by chronic viral infections such as hepatitis B and C. Non-alcoholic fatty liver disease, NAFLD cirrhosis. NAFLD is a non-alcoholic fatty liver disease, NAFLD cirrhosis. This type of cirrhosis is caused by the accumulation of fat in liver, typically in patients with metabolic syndrome, obesity, or diabetes. Autoimmune cirrhosis. This type of cirrhosis is caused by the immune system attacking the liver cells. Cryptogenic cirrhosis. The type of cirrhosis has no identifiable cause. Or idiopathic cirrhosis, cryptogenic cirrhosis. Severity-based classification. Actually, this classification, professors, lecturers, and of the jury, members of the jury, adores to ask about Child-Pugh classification, severity-based classification. Child-Pugh classification. This classification system assesses the severity of cirrhosis based on 5 factors: serum bilirubin, serum albumin, prothrombin time, the presence of ascites, and the presence of hepatic encephalopathy. This is a Child-Pugh, okay? Serum bilirubin. So all right. Make the notes. Serum bilirubin, serum albumin, prothrombin time, presence of ascites, and the presence of hepatic encephalopathy. So based on these factors, patients are classified into one of 3 classes, A, B, and C. No, C, of course, is the most severe. Model of end-stage liver disease, so-called MELD score, a model for end-stage liver disease. It's a MELD. The classification system assesses the severity of cirrhosis based on three factors: serum bilirubin, serum creatinine, and prothrombin time. The MELD scores ranges from 6 to 40, with higher scores indicating more severe disease. No, obviously. Classification systems are important for guiding treatment decisions and predicting prognosis in patients with cirrhosis. However, it's important to note that each patient's situation is unique, and treatment plans should be tailored to the individual needs. Oh, finally, we understand that we have to talk about that. Each patient's situation is unique, and treatment plans should be tailored to individual needs. Yes, great. It's not only concerning cirrhosis. Huh? Okay, diagnosis. No, liver blood tests, coagulation tests, CBC, complete blood count, serologic tests for viral causes, conventional liver imaging tests, imaging, ultrasonography, computer tomography, MRI, non-invasive imaging assessments of fibrosis, transient elastography, now it's very fashionable, acoustic radiation force impulse imaging, no idea what is this actually, honestly. No. Two-dimensional shear wave elastography, magnetic resonance elastography, plus minus proton density fat fraction. Identification of cause based on clinical evaluation, routine testing for common causes, and selective testing for less common causes. Sometimes, now it's actually rare, thanks God, liver biopsy, for example, when clinical and non-invasive tests are inconclusive, or when biopsy results may change management. Well, if we talk about diagnosis, we have to talk about differential diagnosis also. So diagnosis of cirrhosis is usually made based on a combination of clinical, laboratory, imaging findings, like any other condition. But anyway, however, other conditions can mimic the symptoms and signs of cirrhosis and should be considered in the differential diagnosis. Some of the conditions that can be considered are hepatitis B or C. Chronic hepatitis B and C can cause liver damage that may be similar to cirrhosis. These infections can be diagnosed with blood tests, of course, antigen antibodies. Next, non-alcoholic fatty liver disease, NAFLD. Non-alcoholic fatty liver disease, NAFLD can cause liver damage that can progress to cirrhosis. NAFLD, a diagnosis of NAFLD can be made with imaging studies or a liver biopsy. Concerning that possibility that NAFLD can become cirrhosis, actually highly questionable, but of course when we talk about very severe obesity, yes, maybe. But actually it's not a cause, it's a trigger and not a cause. Autoimmune hepatitis, this is a chronic inflammatory disease of the liver that can cause liver damages and cirrhosis. Diagnosis can be made with blood tests and a liver biopsy. Wilson's disease. Wilson's disease, this is a genetic disorder that causes copper to accumulate in the liver. No, Wilson's disease is a copper problem. Huh? Copper disease to accumulate in the liver, bronze disease. Huh? In the liver and other organs, leading to liver damage and cirrhosis. Diagnosis can be made with blood tests, urine tests, and the liver biopsy. Hemochromatosis. This is a genetic disorder that causes excess iron to accumulate in the liver and other organs, leading to liver damage and cirrhosis. Diagnosis can be made with blood tests and the liver biopsy. Alpha-1 antitrypsin deficiency or antitrypsin deficiency. This is a genetic disorder that can cause liver damage and cirrhosis. Diagnosis can be made with blood tests and a liver biopsy. Blood-Chiari syndrome, or blood-Chiari syndrome, no, actually blood-Chiari syndrome. This is actually a very rare condition in which blood clots block the veins that drain the liver, leading to liver damage and cirrhosis. Diagnosis can be made with imaging techniques. It's important to distinguish cirrhosis from other conditions because the treatment and management options can vary and vary significantly. A thorough evaluation, including a detailed medical history, physical examination, and appropriate laboratory and imaging studies, is essential to make an accurate diagnosis and provide appropriate care. Yeah. Prognosis. Prognosis for cirrhosis varies depending on the underlying cause, severity of liver damage, and other health factors. Cirrhosis is a chronic and progressive condition, and once liver damage has occurred, it cannot be reversed. However, with appropriate treatment and management, the progression of cirrhosis can be slowed down and complications can be prevented and managed. The Child-Pugh classification and MELT model for end-stage liver disease, MELT score are commonly used to predict prognosis in patients with cirrhosis. Child-Pugh classification uses 5 clinical parameters to assign patients to one of 3 classes A, B, C. So once again, with C being the most severe, and the MELT score uses 3 laboratory tests, laboratory values to predict mortality within 3 months. Both Child-Pugh classification and MELT score take into account liver function and the presence of complications, such as ascites and hepatic encephalopathy. The 5-year survival rate for patients with cirrhosis varies widely depending on the severity of liver damage and underlying cause. For patients with compensated cirrhosis or minimal symptoms, the 5-year survival rate can be as high as 85–90% with compensated cirrhosis. However, the patients with decompensated cirrhosis means presence of complications. The 5-year survival rate drops to 50% or less. Patients with hepatocellular carcinoma and cirrhosis have a particularly poor prognosis, with 5-year survival rate or less than 20%. Oh, that's carcinoma. Early diagnosis and appropriate management are key to improving the prognosis of cirrhosis. Treatment may include lifestyle modifications such as abstinence from alcohol. This is quite important, absolutely important. It's a hallmark of treatment. We will talk about treatment, so abstinence from alcohol and weight loss, medications to manage complications such as portal hypertension and hepatic encephalopathy, and in some cases, liver transplantation. Regular monitoring and follow-up are important to detect and manage complications early and prevent disease progression. Management or treatment. The treatment of cirrhosis depends on the underlying cause, severity of liver damage, and the presence of complications. The main goals of treatment are to slow down the progression of the disease, manage complications, and improve quality of life. As any goal of any treatment of any condition. So lifestyle modifications. Of course, first of all, as any other chronic condition, first point is lifestyle modifications. For patients with alcohol-related cirrhosis, abstinence from alcohol is crucial to prevent further liver damage. In addition, weight loss and regular exercise can help improve overall health and prevent obesity-related liver disease. Medications. Medications may be used to manage complications of cirrhosis, such as diuretics for ascites and edema, lactulose for hepatic encephalopathy, and beta blockers or nitrates for portal hypertension. Antiviral medications may be used to treat chronic viral hepatitis B or C. It's very questionable about these antiviral medications. No, anyway. Nutritional support. Patients with cirrhosis may be malnourished due to poor appetite, dietary restrictions, and malabsorption. Nutritional support, including a well-balanced diet, vitamin and mineral supports, and enteral or parenteral feeding may be necessary to prevent or manage malnutrition. Liver transplantation may be an option for patients with end-stage cirrhosis. So we find surgery, means transplantation, of course. Liver transplantation may be an option for patients with end-stage cirrhosis who have failed medical management or have development complications such as carcinoma. A liver transplant can improve survival and quality of life, but the availability of donor organs is limited, and the procedure carries significant risks. Actually, it's a utopia. Management of complications, of course. Complications such as ascites, varicose bleeding, hepatic encephalopathy, and carcinoma require specific management strategies such as paracentesis for ascites, endoscopic band ligation, or sclerotherapy for varicose bleeding, and local ablative therapy or surgical resection for carcinoma. Screening for carcinoma. No, we talk about hepatocellular carcinoma, of course. Patients with cirrhosis are at increased risk of developing carcinoma, and regular screening with ultrasound and alpha fetoprotein (AFP) is recommended to detect HCC early when it's more amenable to treatment. It's important to know that the cirrhosis is a chronic and progressive condition, and once liver damage is occurred, it cannot be reversed. However, with appropriate treatment and management, the progression of cirrhosis can be slowed down and complications can be prevented or managed. Regular monitoring and follow-up are essential to detect and manage complications early and prevent disease progression. Prevention of cirrhosis involves identifying. It's actually the same thing. I find a question like this, so I have to answer. Prevention of cirrhosis involves identifying and treating the underlying causes that can lead to liver damage and adoption a healthy lifestyle to maintain the liver health. Some of prevention strategies include, of course, first of all, it's avoidance of alcohol. Excessive alcohol consumption is one of the leading causes of cirrhosis. Limiting alcohol intake or avoiding it altogether can reduce the risk of developing cirrhosis. Vaccination of viral hepatitis B and C are the most common causes of cirrhosis. Vaccinations for hepatitis B and early detection and treatment of hepatitis C can prevent liver damage and reduce the risk of cirrhosis. Safe sex practices, hepatitis B and C, actually these are sexual transmitted disorders. We know that can also be transmitted through sexual contact. Using barrier methods of contraception such as condoms can reduce the risk of infection. Avoidance of risky behaviors, injection drug use, sharing needles, and unprotected sex with multiple partners can increase the risk of contracting viral hepatitis and other infections that can lead to cirrhosis. Maintenance of healthy weight. Obesity and non-alcoholic fatty liver disease, NAFLD, are risk factors for cirrhosis. Very obese persons, yes. Maintaining a healthy weight through a well-balanced diet and regular exercise, of course, can help prevent obesity-related liver disease. But this is actually a question not of consumption of fatty products. No, this is a question of so-called diabetogenic sugars, glucoses. White meal and white sugar. This is the most important, and not good fatty fast food, actually. Non-saturated fatty acids. Medication. Certain medications such as acetaminophen and non-steroid anti-inflammatory drugs can cause liver damage if taken in high doses for prolonged periods. We know that. It's important to follow the recommended dosage and avoid over-the-counter medications unless advised by a healthcare provider. Regular checkups, regular screening and monitoring of liver function tests and ultrasound can help detect liver damage early before it progresses to cirrhosis. So actually, in summary, prevention of cirrhosis involves avoiding or managing the risk factors that can lead to liver damage, adopting healthy lifestyle practices, and seeking medical care any other for any underlying liver conditions. And finally, rehab. Rehabilitation is an essential part of the management of cirrhosis, especially in advanced stages. The goal of rehabilitation is to improve the quality of life of the patient, prevent complications, and slow down the progression of the disease, not like any other chronic condition. Rehabilitation programs for cirrhosis typically involve a combination medical, nutrition, and social support measures. Uh, Medical management. Patients with cirrhosis require ongoing medical management to manage their symptoms, prevent complications, and improve liver function. This may involve medications to manage complications such as ascites, hepatic encephalopathy, and portal hypertension. In some cases, liver transplantation may be necessary. Nutrition support. Patients with cirrhosis often have a nutritional deficiency and require specialized diets to maintain their health. A nutritionist or dietitian can work with the patient to develop a healthy eating plan that meets their nutritional needs and easy to follow. Exercise and physical therapy. Exercise and physical therapy can help patients with cirrhosis maintain muscle strength and prevent muscle wasting. Actually, it's okay for everybody. Yeah? Exercise and physical therapy. Patients may work with a physical therapist to develop an exercise program that is tailored to their abilities. Psychosocial support. Patients with cirrhosis may experience depression, anxiety, or other physiological issues related to their condition. Counseling of support groups can help patients cope with the emotional aspects of their illness. Substance abuse treatment. Patients with cirrhosis who have a history of alcohol, drug abuse may require substance abuse treatment to prevent further liver damage. Social support. Patients with cirrhosis may require social support to manage the daily challenges of their illness. And social workers, case managers, and support groups can provide practical assistance and emotional support to patients and their families. So, rehabilitation for cirrhosis involves a multidisciplinary approach that addresses the physical, nutritional, psychological, and social aspects of the disease. The goal is to improve the patient's quality of life and prevent complications, and it requires ongoing collaboration between the patient, doctor, and their support network. So, my friends, you see, 35 minutes I'm talking about one question. Of course, it's impossible to answer in this manner on the big exams. But anyway, this is a full, I answered all the questions that I find in your examination tickets. Actually, the beginning is the most important. Huh? So, re-listening this video several times, make the notes. Don't forget to make the notes. Re-listening several times, and you will remember. Instead of doing I don't know what. So, my friends, thanks for your attention. See you in another lectures. Don't forget to follow and subscribe the channel. Bye bye, and God bless you.